Good morning. I'm Dr. Edward Mills. I'm a practicing dentist in Atlanta, Georgia. I'm the director of the Medical College of Georgia's Comprehensive Dental Implant Program. Today, first of all, I want to end up welcoming you to Dental XP. I'd like to end up sharing with you a couple of thoughts of mine on utilizing narrow implants in the aesthetic zone. For a period of time, clinicians have established predictable parameters by where we could end up spacing implants in the aesthetic zone in such a way that we could end up optimizing aesthetics. Exposito described that ideally you should end up having 1 to 1.5 millimeters between a tooth and a dental implant. Dr. Tarnow further suggested that you should end up having 3 millimeters between dental implants. Dr. Tarnow and Kois further described the relationship between the interproximal bone and the contact of the clinical crowns. He suggested that if you had 4 to 5 millimeters of distance between the interproximal bone and the contact of the crown, the papilla would fill in and thus you would have the optimum aesthetic results. We could end up changing the shape of the clinical crowns to end up being consistent with this parameter by, for example, taking a triangular crown and by making it square, we could end up dropping the lowest contact point and get the results. Dr. Salama Garber-Nadar took some of this information and ended up adding a relationship not only between interproximal bone and distance, but showed the relationship between interproximal bone distance and bone to contact distances in tooth to tooth, tooth to pontic, tooth to implant, pontic to implant, implant to implant, and pontic to pontic. And gave us really specific insight on what we could expect predictably in the aesthetic zone, such that if we placed the implants ideally and had the right contours of the crowns, we would end up getting the cosmetic effect that basically fulfilled the patient's expectations. The challenge has come in that there are certain clinical situations, especially in maxillolateral or mandibular anterior, that there's just not going to be adequate space to place an implant between of adequate width, or convention of adequate width, and the interproximal and the adjacent tooth, because there's just not enough interproximal distance. The relationship of the implant, as it exits the bone, or the trajectory of the implant, was also critically important in obtaining the appropriate aesthetic results. We ideally wanted the implant to end up being parallel to the incisal edge of the adjacent teeth or slightly lingual to the incisal edge of the adjacent teeth. The very first implant that came out that was smaller than 3.3 millimeters was the Maximus, the BioHorizons Maximus 3 millimeter. It was a 3 millimeter diameter implant which allowed insertion between interproximal space that was as small and what we decided was 5 millimeters, and thus could be restored aesthetically, right, or obtain the right aesthetic results. The challenge in this was a one-piece implant. The reason that it was a one-piece implant was we needed to end up having adequate strength at the abutment implant interface. But the challenge was that you had to surgically insert the implant in such a way that it was slightly lingual. If not, we had some additional aesthetic challenges that we had to end up addressing. Oftentimes the trajectory of the bone doesn't necessarily lend that. There are some ways, there are some things that you can end up doing that you can end up placing narrow implants in such a way that they can be restored properly. I like to end up sharing some of those. First, let me end up showing you that this is a Maximus implant and it is being inserted slightly lingual to the adjacent teeth. And in this situation, it's a fairly easy implant to end up restoring. The rationalization for utilizing narrow implants is obvious. Anytime that you have inadequate space, both buccal lingually, such that you can't place a 3.5 millimeter, implant, then you need to look for some different, options. The one-piece 3 mm implant had some significant advantages. The one advantage was not only was it stronger, it didn't have an implant abutment, interface, so it was one piece. You didn't end up having any microspaces between the abutments. You didn't have any micro movement of the abutments. You had less chance of fracture of the implants, less chance of mechanical breakdown, and you had the elimination of any bone changes that took place sometimes when you moved that up, took that abutment on and off. This is the original BioHorizon Maximus dental implant, one-piece 3 mm implant. Let me show you a couple clinical cases which we utilized the Maximus implant and how we ended up addressing it. This is a situation where the patient's missing tooth number 10. When you end up looking at, she's got 5 mm of interproximal bone between tooth number 9 and tooth number 11. When you end up looking at the CAT scan, you can see that there's some other challenges that need to be addressed. Not only is there minimal distance between the interproximal teeth, but the buccal lingual concavity that you often see in these cases also created a challenge. So when you end up placing, this implant, you want to obviously center it between the two, adjacent teeth, and hopefully you've got at least 1 mm of available bone. And in this situation, we had 5.2 mm, so we just barely had 1 mm available bone. The implant was ideally placed. But you would like to end up placing that implant so it's slightly lingual to the adjacent teeth, but you need to keep it between the two cortical plates. So here is a CT 3D model with the implant and the trajectory in an ideal position situation. If you end up looking at this, even with the implant ideally positioned with bone expansion, the trajectory is still going to be slightly facial to the incisal edge, which is going to end up creating the aesthetic challenges that we addressed earlier, or we at least discussed. So by tipping the implant slightly forward and possibly using some bone expansion techniques, we can place this implant such that it can be properly restored. When we end up placing these one-piece implants, not only do we use the manufacturer's surgical kits, which uses 1 or 2 osteotomy burrs, but we also use a series of osteotomes. Usually we under-prepare the osteotomy using bone spreaders. For example, if we're going to end up placing a 3 mm implant, you don't want to end up spreading the bone more than 2.7 mm in diameter, such that we can end up getting the optimum stability of the implant at the time of surgery. When we end up preparing this, our incision and our reflection is fairly uniform. We do an intercircular incision, and we come across the lingual, and then we reposition the soft tissue to the facial. While the blood supply anastomosis from both sides, and the ideal insertion is right at the mid-crest, by repositioning the tissue to the facial, not only do we enhance our keratinized tissue, but we increase our vertical height, which is going to enhance our aesthetic options down the road. Once this tissue is reflected and we see the crestal, bone, we try to minimize any further reflection on the facial unless we're going to do some additional guided bone regeneration. Now, the BioHorizon has a very nice alignment drill, which allows for the initial access into your preparation. This alignment drill creates our first penetration through the cortical bone into the medullary bone. And once we do that, we can actually place a trial insert that mimics the prosthetic head of the final implant. Once that trial insert is put in place, we can end up spreading the bone using handheld, bone expansion techniques with osteotomes. Oftentimes, I will use a very small initial osteotome and split the cortical plates, and then I will expand it to a 2.7 mm diameter osteotomy. Now, you can end up not using a bone expansion and using a secondary drill that conforms with the diameter or slightly smaller diameter of the implant. But in the maxilla, what we found out is once you make that initial penetration, I would prefer to end up making my osteotomy strictly with osteotomes. Now this is the implant, the BioHorizon implant as it comes in the kit. If you notice that it has a carbide burr which can be utilized to prepare the abutment at the time of surgery. So we insert the implant. You can use a ratchet or a linear driver, and you end up threading it into the osteotomy. I usually try to put some pressure towards the lingual such that we can end up having the implant as far back towards the lingual as we can. So I'm pushing against that lingual cortical plate. And once the implant is inserted, you notice that the tissue we take into the lingual is now positioned to the facial. This has enhanced our amount of keratinized tissue, but it's also increased the vertical height of soft tissue. Salama describes a sort of vascularized connective tissue graft in which he tucks that soft tissue in itself. What I found out is that we just leave it long, and over time, when we put the provisional in place, this will end up reshaping to an optimum form. There is the implant in place in between the teeth. And now the implant is inserted to ideal. We use the carbide burr to end up preparing it right in the mouth. And this BioHorizon implant, you're going to have to do a conventional impression. Some of the other one-piece implants, which I can describe later on, utilize a snap cap or abutment system or a snap cap impression technique in which you have an actual implant analog. But again, the BioHorizons did not lend itself to that initially, so you did have to prepare it. You did have to take a conventional impression. Now, once the implant is inserted and the abutment is prepared, you can end up making an ideal provisional, crown, and you could end up putting pressure against the facial tissue so as to form an ideal, contour. Oftentimes, we would end up placing this crown, in and put an Essex appliance over it right at the time of surgery, put it in with Neosporin, and what you see at 2 days is the soft tissue still looks higher, on the facial, and at 10 days, you start seeing that the soft tissue starts getting recontoured. You still have more soft tissue on the facial than what you need. I would just give it time. And after the soft tissue is finally healed, without doing any type of electrosurge or laser treatment, just letting the provisional crown-shaped tissue, you can get a nice, thick, keratinized tissue with adequate biotype, on this, implant. Then we just placed our ceramic or zirconium crown, in place and inserted into, on top of the implant in a way that that hopefully works for the patient. Now, another situation besides the maxillary lateral that you oftentimes have a challenge is when a patient is missing a mandibular anterior tooth. Oftentimes, either through congenitally missing mandibular incisors or loss of teeth, the patient comes in with some spacing challenges that don't lend the restoration with a conventional, implant. This is a situation where you can see the patient's missing 26. After orthodontic treatment, there's some space that is created to end up hopefully restoring, with an implant number 26. But if you end up measuring the distance between between tooth numbers 25 and 27, you're not going to have 7 millimeters of interproximal distance there. You'll barely have 5 millimeters. And you can also look at the concavity of the soft tissue, on the facial there, which is going to create an additional, challenge. Now again, ideally you want to place this implant directly interproximal between the teeth and slightly lingual to the incisal edge, or really at the cingulum of the adjacent teeth. You can see our post-op Panorex that the roots are properly aligned up, but there's just minimal distance there to end up placing an implant. And when we end up doing our CT analysis, we can see that you can place a 3 millimeter implant in between the cortical plates, and it should be initially inserted slightly lingual to the crust. So you don't want it to conform with the initial trajectory of the tooth. You want to have it slightly lingual to it so that when it ends up exiting the soft tissue, it's going to be lingual to the incisal edge of the adjacent teeth. And here you can end up seeing the occlusal view of the implant ideally positioned in a slightly lingual direction as compared to the adjacent teeth. And you can see the 3D reconstruction with the implant inserted. You can see the concavity there and the optimal implant insertion. Now again, we're going to end up using the BioHorizon implant in this situation, and then I'll end up showing you some of the other implant systems that have ended up coming into the market after the Maximus implant. You can end up utilizing platelet-rich plasma or some other physiologic enhancement property to end up improving the revascularization. We try to end up minimizing the flap designs, on this so that we lose very little bone, because the bone is going to be very thin, on these implants anyway. And any loss of revascularization is going to create some dieback. So by using PRP, you can expand the speed of revascularization and thus decrease the likelihood of bone loss following surgery. Here we have our initial alignment drill that we're end up placing right between the two teeth. We end up placing some PRP right into the osteotomy. I'm not confident that the PRP in the osteotomy is really making a significant amount of difference, but we suggest that it might help not only revascularization in the flap, but it might enhance some of the revascularization within the bone. Now, once the osteotomy is end up preparing, we end up inserting the implant between the teeth and end up driving it into place using hand ratchets. Once the implant is inserted, and you end up looking at the trajectory, and hopefully it is positioned as we described, lingual to the incisal edge of the teeth, then you can end up making a provisional crown. The orthodontic wire actually serves as a great guide in placing narrow implants during orthodontic care, so generally we end up doing all of our procedures with the orthodontic wire in place. Once the implant is in place, you reduce it in the mouth using copious irrigation such that you can end up placing a provisional crown that with the desired contours that you want your final crown to end up being. You reposition the implant to the facial. If you've got too much tissue, you can end up de-epitheliating the top form of it, and you can tuck it in such that you can increase the width of your keratinoid tissue, so it really becomes somewhat of a vascularized connective tissue graft. And then you just secure the tissue in place. And here you've got a large, I think this is an 18 millimeter long 3 millimeter implant between tooth number 26 and tooth numbers 27. And you note that you have no more than 1 millimeter in between. And you can see that the root trajectory doesn't give you a whole lot of room for error. Here's a occlusal view of the implant in place. There was a little bit of inner proximal slicing, and we're trying to end up widening, widening the space so that we could end up making a crown that is more ideal, in shape. And here is the implant in place after we've made our final orthodontic, adjustments, and the implant prepared, and then the final restoration, in place.